clinical In her clinical career, she has provided care to adult medical surgical patients with a special focus on oncology and ventilated patients. Her research focuses on the work environment of nurses. Lorraine Bureau is the Senior Vice President of the Nurkin Center for Research and Grants at Parker Jewish Institute for Healthcare and Rehabilitation. She is responsible for the supervision of all institute research and grant development, clinical trials, health services research, and survey design and implementation. Dr. Sophia Brown graduated from the informatics program at NYU Myers. She has been a registered nurse for 27 years and is the senior program manager in nursing informatics at Memorial Sloan Kettering Cancer Center. She enjoys automating and optimizing clinical workflows and implementing change at point of care. Min-Jae Kim received a master's from NYU Myers. He is currently working as a senior nurse practitioner at New York Spine Care and serving as a leadership succession chair at Sigma Theta Tau Upsilon chapter and education committee chair at New York City Men in Nursing. Dr. Sharon Stahl Wexler received her master's and PhD from NYU Myers. She is presently the Amelia A. Gould Endowed Professor for PhD in Nursing and PhD Program Director at Pace University College for Health Professions at the Leonard School of Nursing. Dr. Wexler's program of research focuses on the use of technology to improve outcomes in older adults. Dr. Wexler will serve as the moderator this evening. During the program, please type your questions in the Q&A and we will get to answer as many as we can at the end of the program. By attending this program, you are eligible for contact hours. We will send you an online survey to complete after the program so you can claim the credits.
Okay, I'm now going to begin. And the first thing I'd like to ask all of our panelists is to share their experience with telehealth over the past year during the pandemic. Lorraine, why don't you go first, please?
Good evening. So before I begin, I just want to tell everybody a little bit about the Parker organization. We're a 527-bed nursing home located on the border between Nassau County and Queens. So we have 1 foot in the suburbs and 1 foot in the city. About 180 of our beds are subacute rehab beds. The remainder 347 beds are traditional long-term care nursing beds. Prior to the pandemic, I would say that we had limited experience with telehealth. Over the years, I would say about 10 years prior to the pandemic, we had been involved with several small projects and had some successes, but mostly failures as far as implementation of telehealth. We had a lot of resistance from our providers. We had a lot of resistance from patients. And really not a lot of incentive in terms of reimbursement and regulations that also served as a barrier to using telehealth in our setting in particular.
Noreen, would you like to tell us about your experiences, please?
Sure, thank you. And following Lorraine's path, I will just tell you very briefly, I'm the Chief Nursing Officer of a Safety Net Hospital in New York City. We are basically a community-based hospital. We have capacity for 338 inpatient beds, and annually we see over 300,000 outpatient visits a year. During the pandemic, some of the things that came about during this cataclysmic event was the need for rapid change, not only for our inpatient units, but also for our EDs and our outpatient areas. Probably the biggest challenge that I had to deal with in that event and in this change was the fact that for years we had around the buildings no cell phones to be used, no technology different types of signs we had up. And then we had to overnight shift from that mentality to a mentality where I had to rip up the policy for our cell phones, because that's all we started using: iPads, cell phones, more and more technology. And for those of you who have written those policies in the past, you know exactly what I'm talking about. We felt that with the technology and what we needed to do, we really needed to be working on all cylinders with all of our partners at the table, particularly our medical colleagues, our nursing colleagues, and most importantly now, not only our IT colleagues, but also our facilities colleagues, because when we were going to switch over to telehealth, we're an older building that didn't have places to plug in. We didn't have space. So we needed to repurpose a lot of our areas in order to meet this changing and growing need, because with over 300,000 outpatient visits, we needed a way to connect with our patients that were outside the community.
Thank you, Noreen. Minjay, would you like to tell us your experience with telehealth during the pandemic, please?
Yes, my name is Minja Kim. I'm a senior nurse practitioner at New York Spine Care. Yeah, let me share a PowerPoint slides so that I can give you more detailed information about my experience during the COVID-19 pandemic. Okay, can you see the screen okay?
Yes, thank
Okay.
you.
All right. Yeah, as a pain management nurse practitioner, I really wanted to provide good quality of care, pain care, and try to increase the accessibility with telehealth during the pandemic. So we started the telemedicine from March 2020, and still we are delivering about 70% of outpatient pain management care through telemedicine. Me and other practitioners have been doing our best to support each other and work effectively while minimizing COVID infection risk among patients by using telehealth technology. New York Spine Care provides chronic pain management outpatient care through telemedicine. But if the patient is a candidate for the pain management procedures, we make them to come to our office to do the procedure and injections to manage the symptoms. During the New York State lockdown in 2020, we implemented only the emergency procedures for patients who really needed the help due to the intractable radiculopathy or facetogenic pain. After starting vaccination, our patients have choices to either coming to our office for the follow-up or telehealth for their medication regimen and pain management care. Early 2020, due to lockdown, travel restrictions, social physical distancing requirements, patients avoided visiting healthcare facilities in person. So we saw significant patient numbers decrease in our patient care in early 2020. And patients kept calling us to get their pain care. So we quickly implemented telehealth protocol, and we have changes its protocol continuously to give appropriate care for patients who are suffering from chronic pain. We selected Doximine for telehealth visit. It took weeks for patients to get used to it, especially elderly patients. But now, after a year later, even 90 years old patient knows how to get access to this telehealth by using their phone, computer with their family members' assistance. During pandemic, many patients suffered from increased anxiety, stress, depression due to accessibility of pain care. Eventually, many pain management clinics, physical therapy place, and chiropractic clinics implemented telehealth visit to deliver health education, pain care, support to increase quality of life of our patients. Telemedicine service has offered numerous advantages, especially in routine, non-urgent pain care. Unnecessary and avoidable exposure of the people involved in delivery of healthcare have been prevented. Telehealth has reduced the need of personal protective equipment, leading to reduction in resource consumption. The COVID-19 pandemic presented a unique opportunity to further develop telehealth as the viable means of providing accessible, safe, effective, and high-quality multidisciplinary pain care. Yeah, of course, there are challenges of telehealth in pain care management. There is a lack of clarity on medical legal implications. Use of technology cannot replace clinical medicine based on in-person consultation and physical examination. Also, chances of misdiagnosis and inability to conduct radiological investigations for diagnosis are other limitations. So the risk of COVID-19 will extend well beyond the current period and may last longer. Therefore, in future, even if lockdown is relaxed, telehealth will be attempted by almost all the healthcare facilities, and these will be novel for many. Treatment options such as health education, psychological-oriented self-management are potentially helpful for managing pain and can be easily delivered using the telemedicine. Changing the practice in the current era of COVID pandemic may have a positive, negative, or unforeseen consequences. When we come to redesign health services after the pandemic, maybe telemedicine will be another model care with patients with chronic care.
Thank you, Minjae. Sophia, would you like to share your experience, please, with telehealth during the pandemic?
Yes, I would. Thank you. So good afternoon, everyone. I'm Sophia Brown, and I'm a senior program manager with Memorial Sloan Kettering Cancer Center. As you may know, we specialize in cancer care. We have several inpatient units, and we have units outpatient. We have a large ambulatory care population. It's great now that cancer is no longer a death sentence, it's treatable, and we're getting it more from an inpatient disease to more of an outpatient ambulatory care. We have locations in New York, several locations in New York. We have on Long Island, several, I think 3 areas in New Jersey and in Westchester. So just given that quick overview of the organization, you can imagine with the lockdown, the need for our patient, our critical patient population, to continue to get their care on their cancer care regimen, their follow-up care was, apparent. Prior to the pandemic, we only had a very small footprint with telehealth. There's not much incentive to do care via telehealth. There was no reimbursement was not put in towards that direction. So there was really no much incentive. So what we did, well, the first piece, the buses are closed, or you're hearing, social distance, stay home, especially if you're ill, stay home. So our patients were afraid to come in for their office visits. So we had to find a solution for them. And nurses and healthcare professionals are very creative. So people were using Jabber, some people were using WhatsApp, they were using FaceTime, they were using Doximity, they were using anything that their practice had at their disposal to reach the needs of the patients. I'll talk more about some of those technologies later, but I must share an experience on the inpatient unit. So yes, you normally have like a telemetry device monitoring, but with the COVID pandemic, we've had a greater need. Now the patients are in the room, and we're trying to protect our clinicians. We don't want all our nurses to be sick. We won't have anybody to care for the patients. So with innovation, we're biomedical device department or IT department, nursing informatics, we were able to extend that visual display from the room to the nursing station just to be able to monitor the pulse oximeter for the patient. So that was one of the first indicator that the patient is going downstream. And then another thing now, the patients, they're now isolated. We're not going to the room frequently. So we use iPads. There was an iPad at the bedside. Yes, we have our call bells, but that's kind of for one direction. We wanted to be able to tap in. How are you doing there? So we did a quick iPad implementation. And I'm telling you, the staff, the patient, everyone was really so flexible and just buy into the process, and we made it all work. So high level, it was really an experience where we saw talk about true cross-functional team collaboration. That's what we experienced.
Thank you, Sophia. Can you tell us, Sophia, what was the one biggest challenge you faced with telehealth?
The biggest challenge was lack of standardization. You heard I mentioned all these different ways just to reach our patients, but think about the data, right? Think about now you're reaching the patient, but we want to make sure we are maintaining the HIPAA. We are supposed to be HIPAA compliant. And then we want to make sure we are not increasing the fragment in healthcare. We want to make sure whatever information we're gathering from the patient that can be used to care for them. So the standardization just to get, all the providers on the same technology, and education. Some persons really did not know how to, both from the provider side and from the patient side. Because with any app, the patient will have to download it on their phones. The provider would have to have the same, and there's need to be a way to schedule them and have that conversation. But if you should ask me just one, it's really lack of standardization while we're trying to reach out to provide care.
Sounds like it can be quite a nightmare. Noreen, can you tell us your biggest challenge? Was it similar to Sophia's, or did you face something unique at Metropolitan?
So very similar to what she's expressed. Our thing is everybody wanted to come up with a solution very quickly, but what ended up happening is we weren't really at the beginning working as a team. So we'd have devices arrive that would say, let's do the blood pressure, the pulse, and the O2 saturation, but yet no telemetry. So you had this disconnect where, we needed to know about the pulse oximetry, but we also needed to know the other vital signs. So for me, it was the interconnectivity between devices, EMR, and then getting the clinicians on board while they were trying to concurrently take care of patients in the midst of a pandemic. A lot of these creative, great ideas all were occurring as COVID was unraveling during that first wave. But we learned from that. And I think when you talk about the challenges, you always have to look at, the opportunities, which I'm sure we're going to talk about. But for us, it too was kind of close to the interconnectivity with devices and the EMR. And, what we really kind of learned is, do we really have the bandwidth, not only with our Wi-Fi network, but also with our electrical outlets? Because many of these devices required some type of charge or protection or whatever. So, and then cleaning, at the beginning there, do you remember COVID lived on everything, including the bottom of shoes? So, so, there was, so those were kind of some of the things that you really don't expect. You kind of just think, all right, I got my cell phone, and you make an assumption that everybody knows how to use these devices. If I didn't have 4 teenage children, I wouldn't know how to use half of them.
Lorraine, what's the biggest challenge that you faced? Similar to Noreen and Sophia, or something unique, perhaps because it's a long-term care facility and a rehab facility?
So I think Noreen and Parker had some of the same experiences, but I think very uniquely, we had to build something overnight, right? The changes in regulations came out very quickly, and overnight we had staff that had COVID. We had staff that was afraid to go to bedside. We were trying to preserve staff and figure out how we would muddle through this. So very quickly, in one day, we had to come up with a solution that would work. And surprisingly, we had people that did not know how to use iPhones or an iPad. We had to press every tablet and every phone that we had available into service. And we did have trouble with outlets and bandwidth, all things we ultimately overcame 6 weeks later, but we did really build it overnight. And we were very impressed by the flexibility of the staff and, how willing they were to help each other muddle through and figure out how to use the technology. And I agree, having teenagers as children is very helpful in learning how to help with the technology.
See, they come in handy in some
They're
way.
good for something.
Minjay, you're from a very different perspective, an outpatient perspective. So can you tell us what was the one biggest challenge you faced?
Okay, when we started the telehealth in March 2020, yeah, of course, patient had a difficulty accessing to the new technologies. So it was really difficult to teach them how to click it and how to start the telehealth. But eventually, a month later, everyone got used to it. And now it seems like it's going on smoothly right now. But the most difficult thing for us was as a private pain management clinic, reimbursement issue. Also, the legal implication has been very difficult situation. There was no guideline. So we've been always contacting to the Pain Management Association to get the new updates. And we try to establish a protocol for our own. And now I think it is settled down.
Okay, thank you. So Lorraine, what was the biggest opportunity you faced with telehealth? Or in different words, what was your biggest success with telehealth?
Well, we were very lucky. In May, we received a grant from FCC that helped us build a telehealth system and really incorporate all of the things that we wanted. So we pulled together the clinical team and asked them what were the things that they needed. And really what they wanted is they wanted us to simulate what it would be like for the provider to be at the bedside. So whether it was digital pulse ox, digital temp, it was really very simple things, blood pressure. So we actually built our own telehealth units. We used iPads. We bought the devices that the providers picked. We brought them into a room, let them pick the devices that they wanted. And that really helped with acceptance. So we went from, I call it 0 to 500 in a very short period of time. But that grant really made a big difference. It allowed us to purchase the devices we wanted, the software that we wanted, and really take the time to develop the policies that allowed us, I think, to be able to continue with telehealth into the future.
Sounds like you were very, very fortunate and that granted a lot for you. Sophia, what was the biggest opportunity you faced with telehealth or your biggest success? You can answer either way.
Okay, so the biggest opportunity as an informatics specialist is that we got the chance to truly support the nurses at the bedside. Normally we are in the back, and when there's something new, a change, something to tell them to do now, we will go do an implementation and leave. But this wasn't the case because we had to be there on the unit with them, just supporting them, showing them how to use the technology, troubleshooting on the fly. So they don't have to be worrying about, oh, this thing is frozen, it's not working. We'll just go right in, get a swap out, and then go ahead and troubleshoot to keep that stress off our nurses, our frontline nurses. So I think that was a great opportunity to truly partner. And I haven't been in bedside for a number of years. So I actually felt useful. I'm like, okay, I've always verbalized that informatics is really the nurse, the bedside, chairside nurses extension, but this was a true time where we could really show our worth, and not only to the nurses, but to our other colleagues, the biotech teams, the IT teams, because before it's just a concept, but now it's really clinical workflows. Think about an IT person, you're saying, okay, this needs to go into that room. You need to put on this glove, this mask, this setup, and you can't be within this direction of the plug. Now we are able to articulate that workflow, they can't teach the nurses, right? We're able to teach nurses based on our understanding of the workflow. The nurses just quickly get it and move forward. So I think that was a great opportunity where we really provided value to the organization, where we're nurses, but we're also have that technical understanding, and we are thinking with data in mind. So it's not only that, okay, here is the device, just go ahead and use it. So in the back end, the nursing informatics and the IT digits team were checking on the data. What is happening? Is there an improvement? Just one example. So when we started discharging patients, we were able to send them home with a pulse oximeter and connect them with an application. And then we had a whole team of clinicians that was checking into that data and supporting the patients remotely. So that was the first time we're doing something like that remotely. So it's just like a great insight into the possibilities that we may have, maybe it would be 10 years down the road, right? But we had to do this quickly and we actually saw value.
Very interesting. Noreen, what was your biggest opportunity or your biggest success?
So for us, it was really the repurposing of different types of machines and getting it really to the bedside providers very quickly. That was really evident when we went from an average daily census in our ICUs of 10 to 53 in literally a 48-hour period. And what we recognized too is we needed to have communication from the nurses to the central station and vice versa. So we actually incorporated video phones into all of our ICUs so that patients could, by the touch of a button, dial out from their room right to a central monitor where everybody could see and connect with patients. For us, you know, it was also too, was how do you take care of the community that is so used to walking into your building for medication refills, for, you know, point of care testing. We had to, on a dime, pivot and provide them with access to things that such as medication refills through their MyChart account. So we did a lot of outreach via telephones with patients to walk them through that process and to get them engaged with that. So we had lots of really creative types of ideas. At the beginning, when we were unsure how we were going to do triage in our ED, we put up a video screen. And we had a live doc at the video screen, and we were able to triage patients before they even stepped into the building to 2 different areas. So we knew that we could isolate them rather quickly. So there was a lot of creativity, and I would say that was the best opportunity. And when you're a little bit free from some regulations and some type of reimbursement type models, the creativity that comes out of the healthcare providers is absolutely phenomenal and something that needs to be harnessed.
I would agree. And perhaps also the suspension of, you know, feeling that you have to ask to be creative, or feeling that you have to get permission. Whereas a pandemic, from what all of you are describing, sort of loosens the perspective that we need permission, or we have to follow the policy or look for a policy. So it sounds like that really led to quite a few interesting opportunities. Minjae, your very, very lovely PowerPoint told us quite a bit about the opportunities that you face with telehealth. Can you tell us what you consider your greatest success with telehealth during the pandemic?
Yeah, I'm really happy to share my experience. The biggest success was increased patient satisfaction. People didn't need to wait for a long period of time before they saw me. It took like 30 minutes in a waiting room before, because we are in very like a busy pain management clinic. But for now, they don't need to wait. As long as they are on the just waiting room in telehealth, I just start the pain management, just telehealth visit care right away. So they don't need to wait. Also, I could spend more time with the patient doing the consultation and giving them more education. Also, for interventions, many of our patients suffer from the radiculopathy and arthritic pain. So if they have more pain after the telehealth, we make them to come to our office to get the interventions like epidural steroid injection or radio frequency ablation. They could come to our office, which is a less crowded setting and more, which is a more safer place to do the interventions. So telehealth gave us, this kind of big opportunity for us to give the good quality of care.
Thank you. And that's an interesting perspective about patient satisfaction, because at face value, one would think that it would perhaps decrease patient satisfaction because it's a new modality. Will patients be as satisfied seeing someone, over a computer screen or an iPad screen? So it's nice and it's gratifying to hear that it did lead to increased patient satisfaction. So, Sophia, can you please talk about one consideration when starting a telehealth program, please?
Only one?
Only one.
So, oh boy.
Or two. You
Okay,
can have
I'll
two
take
if you
that.
want.
So when starting a telehealth program, yes, we have to first think about our population, and not only the patient, but the provider. We have to support each person in the process. So don't assume that although the clinician can assess the patient properly while here, it's not the same dynamic over technology, right? You'll have to teach them the workflows, give them tips and off the trade how to do it. And even the patients, don't assume that because they have an iPhone, they know how to download the app, or they know how to even put the camera before them in a way that you can see it properly. Okay, you said two. And just maintain your professionalism. Just be professional. It's another mode of providing care. It is not an inferior mode. So the same features, the same policies and procedures, the same being totally present with the patient, the same giving them that shared communication, all those pieces need to be in place. And have fun with it. Have fun with it. Technology do fail. Get an alternative, have a contingency plan. Sorry, I cannot count right now.
Thank you. Those were very, very helpful. Lorraine, would you like to add anything? Considerations from your perspective? And you have quite a different environment than the one in which Sophia works. So some considerations for long-term care rehab.
Well, I think that the waiver provided a great opportunity for providers to jump in and get started. And it relaxed a lot of, I'll say, the requirements. We talked a little bit about HIPAA. Sophia mentioned that. Some of those standards were relaxed. I think we have to remember that whatever we do, we should be HIPAA compliant, right? So very important. FaceTime is nice to use maybe, in an interim or a backup. Sometimes things do go wrong. And that could be a solution, but really you have to seek out something that's HIPAA compliant. You have to pay attention to the regulations that affect your area, whether it be reimbursement, whether it be, provider credentialing, location, consent. In our field for long-term care, that's a big challenge, because not only do you need the patient consent, at least half of our patients on any given day do not have capacity for consent. So we need to get permission from families. And there are situations where we may start a visit and the visit may begin and the provider may determine it's really not appropriate. So we have to have, I'll call it, fail-safe, a backup contingency plan, when those situations don't really, fit a telehealth type model. So you really do have to be flexible. You do need a lot of backup, a lot of training. And as Sophia pointed out, is having somebody at the bedside, at the elbow with the staff is very important to acceptance, right? That can't be emphasized enough. There's a lot of discomfort, and if somebody's at the elbow to support with the technology, it really does help with that acceptance. a lot of planning.
I think sometimes we make the assumption that it's the patients that we have to worry about getting acclimated to using telehealth. Both you and Sophia have really highlighted the need to support staff, and the fact that staff come with all different levels of comfort, knowledge, and facility with telehealth. Thank you
Well, if the
both.
staff is comfortable, they'll also make it comfortable for the patients.
Correct. That's a
So
really good
I
point.
think that goes, a long way, especially, we're treating older adults. So there is a lot of resistance to technology. They haven't grown up with technology. But if the staff is comfortable with it, the patients come along.
Point. Thank you. Minjay, you talked very eloquently about your use of telehealth. So post-pandemic, after the pandemic is over, what part of telehealth do you think will be sustained in your environment? I'm asking you to look in your crystal ball and imagine a world post-COVID. So what do you think will be maintained about telehealth?
Okay, let me see my crystal ball here. So when I think about it, I think telehealth can be used widely among primary care providers and specialists, including mental health, pain care, behavioral health for chronic health conditions, and medication management. Also, practitioners can provide coaching support for patients managing chronic health conditions, pain, diabetes, and high blood pressure. Or also, the patient nowadays participate in physical therapy, occupational therapy, and other modalities via telehealth. So even after COVID pandemic, due to the high accessibility, I think telehealth will be used more widely. I think we need to prepare it, in the future.
Okay, thank you. Noreen, being that you're a safety net institution, and it sounds like you did some pretty miraculous work getting telehealth up and running in a very short period of time in that environment. So imagining that if you had more time to develop a telehealth plan for your institution, what would you have done differently?
So thank you for asking that question, because, if we don't reflect back on what we did and talk about what we could do better, we're never going to improve. So there's basically 5 different points that I think I've outlined that I think really need, that we're really focusing on in our organization. But before I even talk about the 5 points, I think really what we need to all do in our respective environments is pull out those emergency plans and add technology in a much bigger way to those emergency plans. I think when I look at it and I kind of laugh a little bit, our biggest technology was walkie-talkies, at one point in time. Now we're talking about rovers, we're talking about iPhones, we're talking about iPads. So I think for everybody, I would just say, that would be one of the first things that I would ask people to take a look at. First thing that we are going to do as we kind of get out of this next wave is we're definitely going to do a needs assessment, and not just a needs assessment of our staff, but also a needs assessment of our communities and our patients. We're going to take a look at what practices of ours close and would be suitable to have as a telehealth. We're going to take a look at all of our providers. Did we meet their needs? Did we not meet their needs? Our nurses. Did it help their workflows, or did it make their workflows much harder? We're also going to take a look at the level of computer literacy around our building. We think not only from a patient and clinician standpoint, but also from a patient standpoint. The next thing we definitely have to look at, especially since many of our safety net hospitals are in older buildings, are the infrastructures. So it's all great and dandy that we want to have everybody connected with some type of telehealth device, but there are people in my community that don't have the ability to charge their devices. So one of the first things that we've done with our auxiliary team is we are looking to implement charging stations in our waiting areas, in our lobbies, so that people can actually come into our buildings and charge their devices.
Like an airport.
Like in the airport, yeah, except in the airport, I think they're still charging you. No, they're free now. But something along those lines, because it's great to have the device, but if you can't charge it because you can't find a place to charge it, it leads to other problems. We also have to take a look at our hardware, our software, and our wireless networks, making sure that they are really all in pristine condition to handle the internet superhighway that we're establishing for all these things. Because I think, like many of us, more and more things have become wireless, which means they have to be on some network. So we don't want them to be like the Major Deacon Expressway and be stuck in traffic all the time. So we have to look at those things. I know Sophia and Lorraine and Minjay, they've all talked about security. That's part of the infrastructure. Security is going to be a very, very big thing. I mean, think about it. How many of you have been Zoom bombed, or your kids' schools have been Zoom bombed? So there is, especially when you're dealing with healthcare and very sensitive data, we have to really have some good programs there. We also have to start to take a look at our outcome measures and reporting from the technology that we're using. We need to really focus on the clinician's experience, the patient's experience. We have to do it from a satisfaction standpoint, from a health outcome point, as well as a financial point. Because as you heard many people say, what we thought we were going to get reimbursed for televisits and telephonic conversations was not what was seen, and there was a significant difference. I think also too, we have to talk about structure, and structure in how the clinicians interact with the patients. What is the expectations that we now build around doing this type of assessment? Is it okay to have your dog barking in the background as you're tending to a patient? Some of the backgrounds that we've seen are very interesting. Camera on, camera off, muting, unmuting. So I think for our clinicians, there's a great opportunity there to also teach and learn. And also talking about branding, having the NYU Myers sign or the Pace University sign behind you. Is that what we're going to set our level of expectation to be? Or is it going to be a bunch of diplomas on a wall? So I think, those are some of the other things that we do really need to talk about. And I do think some of this needs to be scripted for the providers, for the people who call the patients prior to this being done. We have to also talk about how do you reduce the distractions, not only from the patient side, but also from the clinician side. We found that we had to develop quiet booths where we just really had the computer, our background with branding, and headphones, so that the provider was not distracted while they were interacting with the patient. It's not, you can't take your typical exam room and put clinicians in it and say you're doing telehealth. It's really much more complicated than that. And we also want to ensure the privacy. Those rooms back and forth, sometimes the privacy is not that great. We need to teach our patients what the expectations are going to be when you have telehealth. There are a different set of expectations between telehealth and with an in-person visit. And the last thing that I would say, and this was probably one of the greatest learning experiences I have, is that we need to leverage partnerships, not just leveraging partnerships within our own organization, but across health systems, across our friends in Google and Microsoft. We had great opportunities to work with them to develop platforms kind of similar to what Sophia talked about. But we need to forge new partnerships with our IT people. They can't just be a help desk anymore. They have to be there to help us to talk about what are the tools for our futures. We have to check the evidence and leverage the evidence to say, you know what, yes, this is a good idea. These are now the way in which we're going to be establishing our best practices. So we need to start having, if we start with those 5 points and reflect on what we went through during this pandemic, we did a lot of learning, a lot of growing, a lot of great creativity in a year's time. Actually,
Thank you, Noreen. I have one follow-up question, and I'm directing it to you because I know Metropolitan through you quite well, and I'm very much aware that you deliver a lot of mental health services. So can you tell us a little bit about the effectiveness of telehealth in mental health. Minjay spoke about that, as a future possibility and an area to really pay attention to in the future. Did you use telehealth in mental health? And what can you comment on, please?
Sure. So I'm glad that you brought up that point, because there is a well-established body of evidence that mental health is something that really does lend itself to being provided either telephonically or through televisits or telehealth. And what's very, very interesting is if you start to look at some of that research, prior to COVID, only approximately 3% of psychiatrists or psych clinicians use telehealth. Although there was a whole body of evidence saying that it does work and it can be successful. Interestingly enough, throughout the pandemic, that number jumped up to 66% of providers providing telehealth, and which is wonderful, wonderful. What we found is kind of similar to what's in the literature, in that there is some really great positive outcomes, and some of those positive outcomes are actually getting a glimpse into the home life of some of our patients. Many of our patients experience tremendous stress when it comes to social determinants of health. This gives us a picture or a window into their world. It did help us to expand reach to people who may not have had a contact with healthcare providers. So we have found that we've leveraged that technology piece by providing phones to people to help us to reach those people. And you do have, believe it or not, a lot of patient satisfaction with these types of things. Remember, when we had the first wave of COVID, I'm going to speak for myself here, our volumes in all of our patients, our practices, ceased to exist. And not only did our patients not come in, but a lot of our staff didn't come in. And what was very challenging for our patients was, how am I going to get my meds refilled? You know, when you're dependent on a medication such as insulin to keep you going, it's a really, really scary thing. So the virtual care provided that safety net there for them, and that was really a positive outcome. But with every positive, there are some negatives. And, some of the negatives that you do have, particularly when you're dealing with psych patients, is that you lose that ability when you have a face-to-face to pick up on some of the nonverbal cues that some of the psychiatric patients will display. And I'm sure for many of you who've been on Zoom, I believe most of the people on Zoom just get dressed from the waist up, so you can kind of equate to that. Sometimes there's less patient privacy. We've all experienced this on Zoom. Everybody can hear what you're saying. So that's a concern and a drawback. Some clinicians kind of shy away from the video use for the simple fact that it's difficult sometimes to hear patients when you're trying to have that dialogue back and forth through a video. Some clinicians struggle with, how do you manage time during a visit? There's a different cadence, a different way of communicating. People deal differently with technology. So that's some of that. And then also too, patients and clinicians can become distracted while on Zoom. You take a look at your cell phone, the dog is barking, the child needs to be fed. There's many different distractions that can happen. That doesn't happen in a closed area. However, with that being said, there have been multiple studies that have shown that with certain populations of the psychiatric patient population, that this is a good modality to go with. We will continue with it, and we have been doing it, and we've had great success.
Thank you. Lorraine, would you like to comment on Parker's use of telehealth for mental health? Because I know Parker does a wonderful job meeting the psychosocial and psychiatric needs of their patients. Were you able to use telehealth for that purpose as well, or did you face different challenges?
So initially we started using telehealth for, I'll call it, the primary kind of routine nursing home visits that occur. And there are thousands of those that we do each month. As we got that under our belt, adults, we've moved towards including some behavioral health and actually even other disciplines, transitional care planning, social work, dietary. Because of our environment, I mentioned to you earlier, we do a lot of work with families. So a lot of those planning meetings that we would normally do face-to-face, we're using telehealth for those kinds of meetings as well. So we've included a lot of other disciplines. We're actually looking to hire psych MPs because we've had such an expansion in that area. And I think as Noreen pointed out, this is a perfect opportunity to serve clients that can't get into an office or don't have access for a variety of reasons, including COVID.
Thank you. Thank you for bringing in the interprofessional aspect as well. And that is critical as well. So I would like to thank all of our panelists for sharing your work and experience with us. A lot of commonalities between you, but there are some very unique perspectives that you each shared. So we do have time for questions. If you would like to ask a question, please type it into the chat. Okay, so let us take a look and see if we have questions. Okay, we have 2 questions. And the first one is, this is an interesting question. And the question is about quality patient care. Minjae, could you tell us, do you believe that you met your markers for a quality patient care? And how did you do that using telehealth during the pandemic?
Okay, our patients have limited range of motion. Some people are in wheelchair. They have difficulty getting the transportation. So when they have the telehealth, it really increases the access to the healthcare too. So it has numerous like advantages, such as like especially in routine non-urgent pain care, due to its accessibility, safety, and effectiveness. But if they are in severe pain, we need to see them in person to do the interventional pain management procedure. So we can do the hybrid kind of setting. We can do the just a regular visit with the telemedicine. Also for some patient, we can make them to come to our office to give the right care. So we can, I think in the future, we can use both to give the better care for the patients.
Thank you. Next question is, Lorraine, was it easy to secure your grant for telehealth?
Yes, I think that under the circumstances as a nursing home provider, we were well criticized for how we handled COVID. And I think we were able to use those criticisms to our advantage. So it was not terribly difficult.
Okay. Okay, and it sounds like you did a lot of good with that grant. And this is for any of the providers. Is reimbursement the same for a telehealth visit as it is for an office visit? Who would like to take that one? Any of the presenters? Go ahead, Lorraine.
So under the waiver for Medicare, the same charge for a telehealth visit, including one that's on the telephone, one that's through video, or other means, is reimbursed the same way. That may change in the future, but during the PHE, and I think that rolled back to March 1st, those visits were reimbursed at the same rate.
Okay.
And you do want to be careful and make sure that you meet all of the billing criteria.
Correct.
But we were spending sometimes even longer on video conference calls than in office visits. And it was frustrating in the beginning that the reimbursement was quite terrible.
Okay. Next question. How do you meet the needs of patients who cannot afford a computer or an iPad. And I'll expand that as well. New York City is an area where many of our patients, particularly Noreen, I'm thinking of the patient population you serve, Minjay, the patient population you serve in particular. And it's not only the device involved, it's because you can give someone an iPad or a tablet or a phone, but very often it's the Wi-Fi access. I have worked with technology in older adults, and probably the most frustrating thing in my whole program of research has been not being I've always been able to find somebody that is willing to give me the devices to reach out to the older adults. It's usually been the lack of internet access. So Noreen, would you like to comment? What do you do? What did you do for your patient population that either didn't have access to the technology, the devices, or my particular question, access to Wi-Fi?
Yeah, you know what, I'm gonna tell you, we tried as best as we could, but
Right.
there's always room for improvement. And you do bring up very good points. At least in the city now, there are some hotspots that are for free, but again, it's educating people on how to get it. We do work with a lot of donations and a lot of grant programs. So, but in those things, you're not hitting all of the populations. You're only getting slivers or slices of the population. It is an area that we really, really need to do a little bit better in going forward, because there's really not a lot of funding out there for the actual hardware and devices. And it is going to be a challenge, especially if we continue to make that move towards more telehealth. I don't have the answer for that, Sharon. And I think going forward, I think that is something that as nurses and a community of healthcare providers, we really probably through an advocacy perspective will need to address. When we looked at the lockdown, one of the first things that we did figure out is all of the places where people did get free Wi-Fi, and don't laugh at me, but there are
There
McDonald's,
are, yes.
Starbucks, the library. Those were not accessible to my clients,
Right.
my patients. So they would come into my building and I'd be like, here, sit here, we got guest Wi-Fi. I had people out on the sidewalks with guest Wi-Fi. So, so there is something that we are going to have to do in the future. And that should be part of our planning.
I agree with you. It's definitely an issue for advocacy. A quick anecdote from one grant that I had obtained to bring technology to older adults in one of the New York City, the NYCHA housing projects, one of the naturally occurring retirement communities. We found that even with Wi-Fi hotspots and boosters, et cetera, that particular housing development had been built a very long time ago with concrete walls. So it was virtually impossible to make sure that our clients had reliable Wi-Fi. And the joke was, because of course, as good nurses, you tell the clients, if you need anything and something doesn't work and you're getting anxious or nervous, just call me any time of the day. So the number of 3 a.m. phone calls to nurse, that computer thing that you gave me, that tablet thing, it's broken. And it turned out not to be broken. It was spotty Wi-Fi. So I definitely think that that's something that when I talk to my colleagues around the country, certain pockets of the country don't have the same issue. But in New York City, I think it impacts all of us, no matter how many, how much riches the organization might have. Our clients might not have the same, might not have that same access. Okay, I think we answered all of the questions that I see. Esteem, do you see any other questions posted that we did not answer?
No, I did. I've been checking. I didn't see any other ones. I think we've covered everything.
Okay, a big thank you to our panelists. I think you provided us with incredible insight, and you certainly did some fine work during the pandemic. I'm gonna turn it back over to Esteem. Thank you.
Yes, thank you to all our panelists. On behalf of the Myers Alumni Association, I would like to thank our panelists for joining us tonight. We appreciate your time and willingness to share your experience and insight about the role nurses have played in expanding telehealth. Please be sure to complete the post-event survey if you would like to receive continuing education credits for your attendance. Your feedback is invaluable as we develop programming for the alumni community. The next event will be a restorative yoga class on March 25th. We hope to see you there. Thank you again for coming, and we look forward to seeing you online again very soon. And everyone have a wonderful evening. Thank you.
Bye-bye.
Bye.